I'm Dr. Pallavi Vassal. So I've been working here for quite some time in the Obs and Gynae department as a director for some time as of now. So we do laparoscopic surgeries over here, and we do cancer, so lap onco cancer surgeries as well. So welcome to all of you. So first of all, whenever we take a patient, so what we start with is making a primary port or through a Viries needle or a direct entry, whatever you are comfortable with. So Viries port is something which gynecologists often prefer, but direct port entry is also okay if the abdomen there have been no previous surgeries or anything, then direct port entry is also, it works well. Now typically the incision is usually given over the umbilicus. So why we give it over the umbilicus first, and we can give it anywhere else as well in the abdomen as needed, but usually umbilicus, that is the weakest point, the weakest site. Rest of the abdominal wall, it has like couple of muscles which the number of layers they reduce in the umbilicus, as everyone knows. Rest of the anterior abdominal wall, it has skin, then comes the subcutaneous tissue, then the anterior rectus sheath, posterior rectus sheath, and the rectus abdominis muscle, then the posterior rectus sheath, and then the peritoneum. But in umbilicus, what happens, the rectus muscle, we don't get the rectus muscle, we only get the aponeurosis of the anterior abdominal, of the anterior rectus sheath and the posterior rectus sheath. So the layers they reduce, and that's why the umbilicus becomes the weakest point for entry, and the entry becomes easier. You don't have to put too much of pressure. Now whenever you are putting a port, if you are doing a direct Viries through a Viries needle, then if we have a thin patient, so in thin patient the direction will be towards the pelvis, which is around 45 degree to the abdomen. This is the patient, so this will be somewhere around 45 degree to the patient and towards the facing the pelvis if we are entering the abdomen through the Viries needle. Now if the patient is obese, as the weight increases, the angle of needle goes more towards the 90 degree. So little obese, we go over here, then here, and in a very obese patient, we enter through a 90 degree approach as well. Same holds true for the direct trocar entry. So initially, and when we are doing the direct trocar entry, it has to be like continuous twisting and twirling. You don't have to like poke it like that. It will be like you will be moving your hand clockwise, anti-clockwise, clockwise, anti-clockwise. The movement should not be very jerky. It should be very controlled in a very controlled manner. Now in a thin patient, the bifurcation of the aorta, it lies 5 centimeter beneath the umbilicus. So you have to be, that's why we pointed towards the pelvis. We have to be very careful. Injuries do happen. They are bound to happen once you start doing the surgeries, but we have to take all the due precaution. Vascular injuries are the worst injuries which shouldn't happen. So we have to be very, very careful. Now once we enter the abdomen through the pelvis, so what we do is we check the pneumoperitoneum, whether we have entered properly or not. That is one thing. Now we can do it through a hanging drop test. So in hanging drop test, on the Viries needle, we put drop of water, 2-3 drops of water, and if that gets sucked inside, that means we have entered the abdominal cavity, and the our Viries needle is at the good place. Another method of doing it is like we do aspiration and see where have we entered. Through a 10 ml syringe, we'll aspirate and then we'll push some amount of fluid. If the fluid goes freely inside the abdomen, that means we have entered the right place. Now the best method of testing which I would prefer is connecting it to the insufflator. So once you connect it to the insufflator, we'll come to know about the actual pressure. Actual pressure inside the abdomen will be somewhere below 6-7, not more than that. If the actual pressure is less, then definitely we are inside the abdomen. That is the best method. Now insufflating, putting the air inside the abdomen. Once put air inside the abdomen, once only if you are very much confirmed that you are inside the pelvic cavity, because otherwise there will be subcutaneous collection of the air, and then that leads to complications. As we discussed, this is so intra-umbilical, usually it's a vertical incision is given. So vertical incision inside the umbilical, that's why it is called intra-umbilical incision. And Now here, when you use the Viries needle, so Viries needle has inner stylet and outer outer cannula, like we have in trocar and cannula. So when you push the Viries needle, the sharp point, whenever Viries needle it touches against a hard surface, a resistant surface, the needle is pushed back. It's only the upper sheath which pierces it, and once it pierces it, the needle pops in back. So this keeps on happening till the time we get 2 clicks. That means we have entered into the abdominal cavity. Now if because of previous surgery or something, because of previous midline surgeries, we are not able to enter through the umbilical or supraumbilical, we go through the palmer's point, which is 2 cm in the mid clavicular line, 2 cm below the subcostal margin. Whenever we are entering through the palmer's line, we have to be very sure that the nasogastric tube has been inserted, and so that the stomach is deflated, there are no contents inside the stomach. In palmer's point we are going to get 3 clicks, and that also 1, 2 and 3. So we have to be very careful regarding the clicks if we are using the Viries needle entry. As we discussed, as the BMI increases, as the weight of the patient increases, the angle of the needle keeps on shifting towards 90 degree, and this is same with the direct trocar entry as well. Here if you see like this, and when the patient is it's almost 90 degree or obese, the more the obese, the more perpendicular you have to go. So now the vessels which are once you enter, you have confirmed everything, your pneumoperitoneum and everything has been confirmed. Now you have to go for the accessory ports, the remaining ports which you have to make. So there are couple of vessels which we need to be careful regarding, vessels which we should be careful about, and the deep vessels. Now the vessels, the superficial epigastric vessels, it is especially because when we take the port over here, if we are taking it in the abdomen, it is always taken in an arc manner, usually in an arc manner. If we go by the anterior superior iliac spine, then we take it 2 cm usually above and medial. So we go that ways, and then under direct vision, trans illumination is a very good method of seeing whether the vessels are there in our path or not, and then we make the entry for the with the secondary ports, we make the entry. Now deep vessels also we have to be careful about. So superficial vessels, as I told you, trans illumination is the best method of seeing. We shouldn't be puncturing. There have been cases where during the secondary trocar, so sometimes what happens when you are putting the secondary trocar, you are, most of us are like, they are relaxed कि अब तो primary trocar डाल गया, secondary trocar, लेकिन you should always be seeing at the screen when you are putting the secondary trocar. You should be confirming the vessels. There have been incidences of gross hematoma formation in the subcutaneous tissue with the secondary trocars. So the vessels have to be identified very nicely before you make the secondary ports. Deep vessel another. Now usually the inferior epigastric artery, it is 3 cm above the symphysis and 5.5 cm from the midline. So if you have to go for any of the surgeries, if you have to go through that site, usually in pelvic surgeries we don't need this entry, but if which obscure, for which we should be careful regarding the inferior epigastric, but yeah, you should know. Then the external iliac vessels, this is important for the primary port. So the vessels, you have to be very careful where the vessels are, because the bifurcation of the aorta into the common iliacs, it happens just beneath the umbilicus, and as the weight increases, it shifts cauda downwards. So जैसे जैसे पेशेंट मोटा होता जाएगा, वो नीचे शिफ्ट होता जाता है. Now retroperitoneal structures, so what we should be aware, how to save our bladder. So in gynae, the most important thing, we are very much concerned about bowel and bladder. So that is the most important thing which we are very much worried about. So bladder shouldn't get injured in any case. That is something which we need to take care, and the ureters. Now bladder, if you look at the anterior abdominal wall, Do for prevention of bladder injury, routine catheterization, or if it is a very short surgery, say if you are going for lap chole or something, you can ask the patient to pass the urine immediately and then you can go ahead with the surgery. The bladder should be empty, it has to be empty. In gynec surgeries, it is preferable because uterus and bladder are very closely linked, so it is preferable that you put a catheter over there. Then if there is a previous low transverse incision, so like Fenton steel incisions which are given usually in cases of cesarean section, you can go 2 cm supraumbilical. And then you can go ahead with the surgeries because adhesions are mostly formed in the umbilical region and those are mostly omental adhesions. But if you have a vertical incision, midline vertical incision, then better go through the palmar point. Now ureteric injury, it is very important to understand, to prevent ureter, that we should be aware of the anatomy of the ureter. Where is it dissecting while we are clamping the uterines and the uterosacral, those are the most important points where the ureter can get injured. So we should take all due precautions so that it doesn't happen. So the abdominal part is something, it enters into the pelvis. The course along the anterior and medial aspect of the psoas, it courses along the psoas muscle se enter. Okay, once it enters the pelvic rim, there comes our role. Then until it crosses over the common iliac vessels, approximately 1.5 cm above the bifurcation of the internal and external iliac. So the pelvic part is it traverses, it courses anterior to the internal iliac vessels, crossing the obturator muscle and turning medially at the level of ischial spines. That's what I was telling. At the level of uterosacral and at the level of clamping of the uterine vessels, we have to be careful. And while obviously, and while we suture the vault in cases of hysterectomy, we have to be careful. Ureter, you can easily identify ureter if you turn the camera towards your light cable towards one side of the pelvis. So through the peritoneum you will be able to see the peristalsis and everything. You just have to lift the ovarian ligament up and you can see the retroperitoneally the ureter moving. Another, if you have any doubt, what can be done is giving IV indigo caramine dye, and if you have doubt, only in those cases the color of the urine will help you in delineating. Bladder injuries is something, there is another important thing which sign which shows us if the urobag, if you feel it is inflated with air, that is also an important sign of bladder injury, because then the urobag gets filled up with the air. And color of the urine, it gives little idea about the bladder injury. It might not, but yeah, we have to be careful about the color of the urine as well. Now, if in cases of any surgery which are like complex, like any kind of onco surgeries or endometriotic, which is dense endometriosis, so it is better that we separate the ureter in before we move ahead with the surgery. Ureteric stenting is also one of the methods which can be done if needed. Now when we initial incision is so ablation, adhesions, this you'll get, I think they'll share it with you. So lysis, and especially using cauteries near the this thing ureter, that the bipolar, it is known to cause lateral spread a lot, so that can also cause damage to the ureteric vessels. In treatment of endometriosis, LAVH, these are the most common surgeries which can lead to ureteric injury. Now internal iliac vessels is something, if we have to go, sometimes in myomectomy we have to go for BUAL. What is it? Bilateral uterine artery ligation. So how that is done, that is important. Everyone should be aware of it. So from the round ligament, behind the round ligament, we enter the peritoneum. We open the peritoneum, we go look for the avascular spaces and go behind till the bifurcation of the common iliac. We go retroperitoneal after opening the peritoneum till the bifurcation of the common iliac into the internal iliac and external iliac. Now clamping the uterine just at the origin, that is the biggest branch of the internal iliac artery. So once we identify the internal iliac, then we can clamp the uterine artery from there. Now uterine artery, you can apply the vascular clips as well. And if the patient doesn't wish to have further babies and she's just getting a myomectomy done, then you can do the ligation or permanent or the cauterization coagulation as well. Here is, everyone knows that these are the median sacral. These arteries are in, this is the bifurcation of the aorta into the common iliacs, and this is internal and external. These are the median sacral vessels. These are important in cases of colpopexies. When you have to do retroperitoneal dissection for colpopexy, the staplers, the tackers are applied at the sacral promontory only. So either you should go little right, usually try to go a little right and dissect it nicely, identify the vessels and the nerves nicely. So because if the tacker is given at the wrong place, there is going to be continuous pain for the patient, one thing, and secondly, we shouldn't be injuring any of the vessels. Now, preventing the bladder from injury, if you look at this urinary bladder, you see a median umbilical ligament, and there are two medial umbilical ligaments and two lateral umbilical ligaments. So we need to identify this the moment we enter into the pelvis. So median umbilical ligament will be very easily able to, if we pull bladder little up, we'll be very easily able to see these ligaments. So median, the bladder lies between the two medial umbilical ligaments. One is median, then two are medial and two are lateral. So the bladder lies between the two medial umbilical ligament. So in cases of extensive dissection, the bladder is usually dissected from there only. First the ureter and then the bladder is dissected between the two, away from the medial umbilical ligaments. And these are usually the ligaments, peritoneal folds. They are not true ligaments, they are false ligaments, they are just peritoneal folds. Now there are a couple of things when we are doing, we should be careful about. It's more of importance in cases of hernia surgery, if someone has inguinal hernia or femoral hernia. But yeah, during the gynec surgeries also we should be very careful. We shouldn't go too lateral, because there are two main triangles over there which are very disastrous if we go and touch over there, especially if you are taking a bite or something. So when you are suturing, that time don't hold the needle while you are tying the knot. If the needle pricks somewhere in the major vessels, then there is a hell lot of bleeding. Now there is one is triangle of doom and another is triangle of pain. So triangle of doom is, why is it called triangle of doom? Because there are the base of the triangle, it contains the external iliac vessels and the vein and the artery. If we injure that area, so it bleeds a lot, we immediately need vascular surgeon for it. Then either we ourselves we train for vascular surgery, like it bleeds too much. So we have to be very careful not to cause any kind of injury in the triangle of the doom. So the apex, and another is another is the triangle of the pain. Now here the triangle of doom and another is the triangle of pain. So triangle of doom, it contains external iliac artery and external iliac veins. So we have to be very careful whenever we are going more lateral, that we shouldn't be injuring any of the vessels over there. And if we are going for any kind of hernia surgery or something, that if you are going for mesh repair, so any of the tackers or any of the clips should not be applied over there, and neither in the triangle of pain. Triangle of the pain contains genital branch of the genitofemoral nerve. Then the patient is going to have continuous pain in the pelvic area. This is the pain triangle and this is the dangerous. So it is what it is bounded in female. The apex is at the deep inguinal ring. On one side there is the vast difference in males and round ligament in females, and another side there is this so that's why we have to be very careful. If we go from the starting, most important is the entry. if your entry is right, 50% of your job is done. So entry, you have to be very careful regarding the entry. There are a couple of structures you should identify at the start of your surgery. First, the normal pelvis anatomy. So we have been taught this in our postgraduates as well. Whenever, even if we are doing abdominal open surgery, we have to screen the abdomen. We have to check the abdomen whether we have, and first check the entry point. First of all, check the entry point. We haven't injured anything while, because entry point is a blind point. We have to be very careful regarding that. In pelvic surgery, you have to prevent bladder, you have to prevent ureter a lot. Bowel injury, obviously it has to be prevented in extensive dissections. Now when the ureter, it crosses near the, now to prevent the ureteric injury during the laparoscopic hysterectomy, if you feel there are too much of adhesions, or we have to go for radical hysterectomy or something, ureterolysis is something we can do. So the ureter, it is done along like the bilateral uterine artery ligation only. We go retroperitoneal, we identify the ureter from there only, and we push it laterally. We remove the peritoneum over it, and we push it laterally and keep it laterally only, so that it doesn't come in our way. Another thing is, whenever we are ligating the uterine artery, the bladder has to be pushed properly down. There shouldn't be, we should never try to tie the uterine or clamp the uterine or coagulate the uterine without pushing the bladder down. So that is something even if we are seeing the uterine, even if you start seeing the uterine, you're not supposed to do that. First push the bladder down, because that moves the ureter away. So you push the bladder down, then only tie the uterines. Secondly, for TLH, better is to use the uterine manipulator cups, which are the Mangeshkar uterine manipulator, which it has a cup on it. It gives a very beautiful plane. You put the cup inside, and once you are cutting the vault, you will be able to see the cup margins. That makes your cutting as well easy. And once you are pushing the cup, it pushes the ureter towards the sides. So that becomes quite easy. And this is like, and the bladder injury, as I told you, if you have pushed it nicely, push it far as much as you need. You shouldn't be having any doubt about it. And try to do endosuturing a lot, because if people, they have done hysterectomy abdominally, and then the suturing is done vaginally, which is very commonly done in the earlier stages. When you are not that good at the suturing, you tend to stitch the vault vaginally. So in that cases also ureteric injury might happen. At the level of the uterosacral ligaments, so go a bit above the uterosacral, I would say half centimeter above the uterosacral ligament for the vaults. That gives good vault suspension as well, and it prevents ureteric injury also. That is important. And regarding the bladder injuries, you should, if you identify it during the surgeries, it is the best thing to do that, so that you can repair it. It can be repaired easily with a 2-0 Vicryl in 2 layers. So bladder injuries, and then catheter has to be kept for some more time. And vascular injuries, especially with the second, so primary site is which we can avoid vascular injuries is like at the port site entry at the different angles. And then if there is slightest possible doubt that we are dealing with some densely adhesions, we are going to get good amount of adhesions or something, go through a Palmer point entry. That is the safest. Then you go through the make a primary port at the umbilicus afterwards.